everyone, Anna here with the Coding Guild. Today we are going to talk about inpatient coding rules again. We will review how and why we need to pick a principal diagnosis, what is at stake, and what the rules are. Let's start by clarifying what the principal diagnosis is in practical terms. Well, in short, it's money. In most cases, for inpatient stays, the principal diagnosis will decide how much reimbursement a facility receives. Whatever the principal diagnosis is, will get plugged into the MSDRG grouper, the software Medicare uses to help calculate payment for acute episodes of care, but then performs all kinds of calculations and logical steps and assigns the patient to one of the MSDRGs, the diagnosis-related groups. This will determine how much the facility gets paid for this given patient. If we assign the wrong principal diagnosis at the beginning of this process, the case will either not get paid at all or will get paid but at an erroneous rate. When incorrect payments happen, two things can follow. 1. The hospital can go broke from all the unpaid treatment they provided but coded wrong. Or 2. The facility makes a lot of unjustified profit on services provided but upcoded, and they will get in trouble for that. As you can see, assigning the principal diagnosis correctly is imperative, not just from a financial but an ethical viewpoint as well. Before we get into the guidelines, let's clarify one more thing. The principal diagnosis and the admitting diagnosis are not the same. The admitting diagnosis is the reason the patient presented for care and why they need to be admitted immediately. For example, they have intractable headaches, nausea, vomiting, and vertigo, or they have bloody stools and hypotension. We might not yet know why the patient experiences these symptoms, but they need care for them right now. These are admitting diagnoses. Principal diagnoses are conditions established after study to be chiefly responsible for the occasioning of the admission. Or in other words, what was the underlying disease what caused such serious symptoms to the patient that they needed hospital care? Having a headache, nausea, vomiting, and vertigo are bad enough, but if there was something else lurking in the shadows, and we found that after studying and treating the patient, that will become our principal diagnosis. Sometimes there is correlation between the admitting and principal diagnoses, other times there isn't. For example, a patient admitted with melena and hypotension can have a gastrointestinal final diagnosis of gastric ulcer, while this other patient arrived with shoulder and back pain and ended up with a diagnosis of an ovarian cyst. Her symptoms were from the musculoskeletal system, but the principal diagnosis is from elsewhere. This is perfectly normal and beautifully demonstrates the difference between admitting diagnoses and principal diagnoses. Alright, now let's get started on section 2 and have a detailed look at the guidelines. Leading up to guideline A, we find the following general instruction for principal diagnosis assignment. In determining principal diagnosis, coding conventions in the ICD-10-CM, the tabular list, and alphabetic index take precedence over these official coding guidelines. In other words, if there is a conflict between the guidelines in section 2 and the instructions in the tabular, alphabetic index, or the coding conventions, we must drop the principal diagnosis guideline in favor of all these other rules. For example, we have a patient who is admitted for liver failure due to accidental consumption of death cap mushroom. All treatment was provided for this condition only. The reason for admission after study is definitely the liver failure. This is what buys the hospital bed. This is what the patient is getting treated for. But the problem arises when we start coding for this case. Hepatic failure due to drugs codes to K7110. And yes, we have a mushroom here and not a drug, but as you can see, it's still the correct category as K71 describes toxic liver disease. Is this the principal diagnosis then? Unfortunately, no, because notice this instruction we have under the category header. Code first poisoning due to drug or toxin if applicable. Because our patient consumed a noxious mushroom, This is applicable to our case, and we have no choice but to overwrite the principal diagnosis guidelines and assign the T code first in order to comply with tabular list instructions. Another example could be a patient suffering from Parkinson's dementia who is admitted for violent and disturbed behavior. Although all the treatment will be directed at the behavioral disturbance, it will still not become the principal diagnosis because the index is using the etiology and manifestation convention, these brackets, to instruct us how to code this case. We must sequence G3183 first, and only then can we code F0281. So again, the principal diagnosis coding guidelines get overwritten by conventions or the index. Now let's see those guidelines real quick. Section 2, Guideline A, codes for symptoms, signs, and ill-defined conditions from Chapter 18 are not to be used as principal diagnosis when a related definitive diagnosis has been established. This is not new. We have the same guideline in Section 1. If we have an established diagnosis, there is no need to assign codes for the sign and symptoms caused by the disease. Guideline B, when there are two or more interrelated conditions, such as diseases in the same ICD-CM chapter or manifestations characteristically associated with a certain disease, potentially meeting the definition of principal diagnosis, either condition may be sequenced first, unless the circumstances of the admission, the therapy provided, the tabular list, or the alphabetic index indicate otherwise. For example, the patient is admitted for shortness of breath and chest pain. Final diagnoses are myocarditis and acute on chronic diastolic heart failure. Both were treated with intravenous drugs. These two conditions are interrelated because they come from the same chapter. The circumstances of the admission don't really help because the patient was hospitalized with ill-defined symptoms, chest pain and shortness of breath, and these could belong to either conditions established later. The therapy provided was the same for both problems, and neither the tabular nor the alphabetic index will have any additional guidance for us. Because there is nothing to guide our hand, either the myocarditis or the heart failure can be sequenced first. What we have to remember though is that our choice of the principal diagnosis will have a profound effect on reimbursement for as long as it is compliant and correct, and only then we usually choose the code resulting in higher income for the facility. In this example, if myocarditis is chosen as the principal diagnosis, the final MSDRG will be 3, 14, 15 or 16, but if we choose the heart failure, the final MSDRG will become 291, 92 or 93. Without going into much detail, this one, the myocarditis, is worth more financially and should be chosen as the principal diagnosis if compliant. If you are not familiar with MSDRG assignments and how the whole thing works, please check out our previous video. The link will be up there and in the description below. Let's change this scenario a little bit and say that the myocarditis is treated with ECMO or extracorporeal membrane oxygenation. Now, because the therapy provided will differ for the two conditions, we don't have a choice in sequencing anymore. The guideline says either condition may be sequenced first unless the therapy provided indicate otherwise. If a condition is treated or examined more by more resource-intense means, we have to make sure that that condition will be assigned as the principal diagnosis so that the case can get grouped into a higher paying DRG. The expensive procedure or workup must get paid somehow. If he is admitted originally for the heart failure exacerbation and the myocarditis is only found later as a side note, then the circumstance of the admission will govern our choice and the heart failure becomes the principal diagnosis. Why? Because that was the condition originally responsible for the patient's hospitalization. Guideline C is almost the same as Guideline B, although this one is talking about diagnoses that equally meet the definition for principal diagnosis but are not interrelated. In B, the conditions were interrelated. Here they just happen to exist at the same time. In the unusual instance, when two or more diagnoses equally meet the criteria for principal diagnosis, as determined by the circumstances of admission, diagnostic workup and/or therapy provided, and the alphabetic index, tabular list, or another coding guideline does not provide sequencing direction, any one of the diagnoses may be sequenced first. For example, the patient is admitted with intractable pain due to sickle cell crisis and bilateral pulmonary embolism. The treatment is the same for both conditions. First, let's make sure that both of these conditions could meet the requirement of principal diagnosis. It is not enough that both of these conditions are present, but would each of these separately occasion hospital admission? Yes, intractable sickle cell crisis can easily do that, and the same goes for bilateral pulmonary embolisms. The circumstances of the admission, the diagnostic workup, and the therapy are the same, and there will be no alphabetic index, tabular list, or other guidelines helping us. Again, we can assign either diagnosis first, keeping in mind the MSDRG assignment and what effect our choice will have on reimbursement. Now, what if the pulmonary embolism is worked up further with a catheter-based angiogram, but the treatment for the sickle cell crisis remains the same? In this situation, the pulmonary embolism will take over because the diagnostic workup and/or therapy is more resource intensive for it. By sequencing this more expensive diagnosis first, we can make sure that the facility will get paid for all the services performed. Guideline D. First of all, let's notice the difference between this and the previous guidelines. We have had two or more interrelated conditions that just exist at the same time, and now we are looking at comparative or contrasting conditions. In those rare instances when two or more contrasting or comparative diagnoses are documented as either or similar terminology, they are coded as if the diagnoses were confirmed and the diagnoses are sequenced according to the circumstances of the admission. If no further determination can be made as to which diagnosis should be principal, either diagnosis may be sequenced first. So if no final diagnosis is established by the provider and we only have working diagnoses as our discharge statement, then both conditions will have to be coded for. This happens in the acute inpatient setting because while the patient is being worked up or treated for a suspected condition, the resources, the room time, the drugs, the contrast used, nursing time is already used up. The fact that we might end up with no diagnosis after all of this expensive workup is secondary. The facility needs to get paid for their efforts in diagnosing the patient and extending all these resources while doing so. Other than that, this guideline is the same as before. We will need to choose the principal diagnosis based on the circumstances of the admission, conventions, guidelines, the tabular, the index, and/or the therapy and diagnostic workup provided. An example, the patient is admitted with abdominal cramping and intractable diarrhea. The discharge summary states severe Crohn's flare versus ommentitis. The treatment was the same for both conditions, IV drugs. As the treatment was the same and there is no further indication on which one bought the hospital bed, either can be assigned as principal diagnosis. But however we decide, both will need to be coded for. If one of the conditions, such as the ommentitis, is further examined via a percutaneous biopsy, then this condition will take over sequencing to cover the costs. The Crohn's flare will still need to be coded, but only as an additional diagnosis. Guideline E has been deleted. Guideline F instructs us to sequence as the principal diagnosis the condition which after study occasioned the admission to the hospital, even though treatment may not have been carried out due to unforeseen circumstances. Or in short, we assign the principal diagnosis as usual, as if the treatment had been carried out. For instance, a patient is admitted for bariatric surgery, but before he could be taken to the OR, he suffers a heart attack. Instead of the gastric bypass, an urgent heart cath is performed. Believe it or not, we would still need to code for the morbid obesity or whatever else was the underlying condition for performing the bariatric surgery, and the MI would be assigned as a secondary diagnosis, whatever strange that might seem. Additionally, we also have diagnosis codes to describe these situations. We can find them under the index entry procedure surgical, not done, and from here we choose the appropriate reason. On to guideline G, addressing complications. When the admission is for treatment of a complication resulting from surgery or other medical care, the complication code is sequenced as the principal diagnosis. If the complication is classified to the T80, T88 series and the code lacks the necessary specificity in describing the complication, an additional code for the specific complication should be assigned. Again, this guideline is not really new. We have the same instructions in section 1. If a complication happens and it is documented by the provider as a complication of care, we will assign the complication code as first listed diagnosis. For example, if a patient is admitted for revision of breast prosthesis due to leakage, assign T8543XA as the principal diagnosis for the complication. Now notice this part of the guideline. If the complication is classified to the T80, T88 series and the code lacks the necessary specificity in describing the complication, an additional code for the specific complication should be assigned. T8543XA is very descriptive. We know exactly what the issue is and what is causing it just by looking at the code. But T8859 is different. Here we only have other complications of anesthesia without further specificity as to what the complication is. For vague codes like this one, if within the T80-88 range, don't forget to assign an additional diagnosis code for the actual nature of the complication. For anesthesia, this could be broken teeth, laceration of the larynx, cardiovascular collapse, anything like that. Guideline H is straightforward. If the diagnosis documented at the time of discharge is qualified as probable, suspected, likely, questionable, possible, or still to be ruled out, compatible with, consistent with, or other similar terms indicating uncertainty, code the condition as if it existed or was established. The basis for this guideline are the diagnostic workup, arrangements for further workup or observation, and initial therapeutic approach that correspond most closely with the established diagnosis. This sounds a little bit like Guideline D, where we were told to assign codes for comparative diagnoses in lieu of a definitive final one. Here we are instructed again to code unconfirmed conditions as if already established. The reason for this is that once the facility uses its resources for workup or treatment for an assumed condition, those resources are gone and will not come back for free. If, for example, we have a patient with suspected hyperparathyroidism and a sestamibi scan is performed, then the technetium-99 radioactive material needs to be paid for, not to mention the technician and all other costs. Regardless whether we establish the diagnosis or not in the end, these costs must be covered. In order to make sure that they are, we will need to assign the unconfirmed diagnosis as the principal so that the case will group into the appropriate DRG and gets paid enough. We also have a note here under Guideline H to remind us that this guideline is applicable only to inpatient admissions to short-term, acute, long-term care and psychiatric hospitals. Why this extra clarification? Because under Section 2 General Guidelines, it was stated that the Uniform Hospital Discharge Dataset definitions has been expanded to include all non-outpatient settings. So while the UHDDS definitions apply to all inpatient settings, this guideline will only be applicable to short-term, acute, long-term care and psychiatric hospitals. Next up is Guideline I with instructions on admissions from observation. The guideline differentiates between medical observations and post-operative observations. Let's see medical observations first. These usually start in the emergency department where the patient proves to be too sick to go home, but not sick enough yet to be admitted, so they end up in limbo in outpatient observation status. The guideline states that when a patient is admitted to an observation unit for a medical condition which either worsens or does not improve, and is subsequently admitted as an inpatient of the same hospital for the same medical condition, the principal diagnosis would be the medical condition which led to the hospital admission. For example, the patient is placed in observation for blurry vision, headaches and pain with chewing. 14 hours later, she is admitted with intractable migraine. According to the guidelines, we assign intractable migraine as the principal diagnosis because that is the condition leading to the hospital admission from the observation stay. The other type of observation was post-surgical. When a patient is admitted to an observation unit to monitor a condition or complication that develops following outpatient surgery and then is subsequently admitted as an inpatient of the same hospital, hospitals should apply the UHDDS definition of principal diagnosis as that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Again, we assign the principal diagnosis that is responsible for the admission. An example for this guideline could be a patient admitted to post-surgical observation for hypotension who is then later admitted with acute blood loss anemia. As per the guidelines, we assign the acute blood loss anemia as the principal diagnosis because that condition is buying the hospital bed for this patient. Guideline J on admissions from outpatient surgeries will have one new instruction for us. The rest is confirmation of everything we have already seen before. When a patient receives surgery in the hospital's outpatient surgery department and is subsequently admitted for continuing inpatient care at the same hospital, the following guidelines should be followed in selecting the principal diagnosis for the inpatient admission. If the reason for the inpatient admission is a complication, assign the complication as the principal diagnosis. This has already been addressed in Guideline G for complications of surgery and other medical care. But here comes something new. If no complication or other condition is documented as the reason for the inpatient admission, assign the reason for the outpatient surgery as the principal diagnosis. This shouldn't really happen in real life, but if there is truly no indication as to why the patient needed to be admitted after their outpatient surgery, we will assign the reason they presented in the first place and assign the reason for the surgery. In our example, a patient is admitted for something following their liver biopsy for abnormal liver function tests. Because we have no other diagnosis for the admission, the abnormal liver function test result will become the principal diagnosis. And the last part of this guideline states, if the reason for the inpatient admission is another condition unrelated to the surgery, assign the unrelated condition as the principal diagnosis. Again, nothing new here. We are to choose the principal diagnosis responsible for the admission. For example, the patient has outpatient surgery for tubal ligation, but then falls off the bed and breaks her arm. She is admitted for fracture reduction. Here the principal diagnosis is the arm fracture because that condition will necessitate the hospitalization. And last but not least, Guideline K helps us with admissions and encounters for rehabilitation. Frankly speaking, there is not much to add to this guideline because everything is so well laid out within. The only thing I would like to highlight here is this section reminding us that aftercare for injuries is coded using the injury code with 7 characters D and not an aftercare Z code. In short, Guideline K can be broken down like so. If the patient is being rehabilitated for a condition that is still present and is probably not going to go away anytime soon, we are to use the normal ICD code for it, such as I69351 for the hemiplegia following stroke affecting right dominant side. If the condition has been treated and it wasn't eligible for an injury code, then we are to use the aftercare Z codes. The guidelines example is Z471 for aftercare following joint replacement surgery for a patient who suffered from osteoarthritis. Osteoarthritis is not an injury, thus the aftercare Z code is used. In contrast, if the same joint replacement was necessary for a fracture and not osteoarthritis, then we need to assign the appropriate fracture code with 7th character D for subsequent encounter. In this situation, the rehabilitation services are part of the patient's recovery from the fracture and they are not related to the joint prosthesis itself. And with that said, we have come to the end of this episode. I hope it was helpful. Don't forget to visit our website for more coding help and free coding quizzes. Thank you for being here with me today. I will see you soon in our next video.